Okay, everyone, this is the new Medicare quality reporting. We're going to be doing this only for the initial evaluations, and you're going to notice this on the billing tab. I have placed this, I had to kind of sneak it into the system, so I have placed this under Medi-Cal. So it's not, it's kind of deceiving. It says Medi-Cal, but this is Medicare, and again, we're going to be doing this only on the initial evaluations. All of our Medicare patients are going to be receiving this questionnaire, which they may complain about. Please let them know. Sorry for all the paperwork, but Medicare does require you to fill this information out. And we're doing it this way because it does minimize our workload quite a bit. That's not something you need to convey, of course, but it does make it a little bit easier on us. So when we get to this billing tab, this first one we should be able to attest to for every single patient that comes in. And this is basically saying that, yeah, we've received a list of current medications and we've reviewed those. They're in the chart, usually in the patient intake information. We've used an outcome assessment, so we have a functional limitation percentage that is in the objective tab, and so that's where it's going to be documented. Again, things that we're already doing. When it comes to the outcome assessment or the functional limitation reporting, that's something that if Medicare audited our books, they would want to see the follow-up to the initial eval as well. It's not something we report to Medicare, but we definitely want to make an effort to get another one of those in the chart. And since a lot of times we don't discharge a patient, we would want to make sure that we do that at some point during their care. We're required to do it at the 10th visit, but if a person's only going to come in for 5 or 6 times, make sure you get a follow-up functional limitation reported so that we have that documented. And then thirdly, on every single Medicare patient, we're doing fall risk assessment, and that's something that we're already doing in our evaluation. We're analyzing gait, we're assessing their balance and strength and mobility, and that's all found in the objective section of each one of our evaluations. So that's not really anything new. It's just checking that you have done that. Now, in the rare event that you can't in good conscience check that or any other box, just leave it blank. We're required to report on at least 70% of Medicare patients. And so if we don't get every single one, that's okay, but try to be as consistent as we can. And now we're going to move on down. So that's one that is checked for everybody. These other ones are checked only as they apply. So as we're referencing the patient questionnaire, we can see that everybody has filled out a geriatric depression scale. And when you look through to score this, anytime they circle something that's in bold, that's a point. So there's one in bold, that's 1. That's not in bold, so you don't count that one. That's in bold, so that's 2, 3, 4, so that's 4 total. So since it's 4 total, you would check down here a negative screen, because it would have to, anytime they have a score of less than 6 on this depression scale, it's a negative result. If they have a score greater than 5, which would be 6 or greater, then you would go ahead and just put a 1 in that box. And this also serves as your documentation attesting that you have either referred them to a mental health specialist or at least recommended that they consider seeing a mental health specialist. You could also document in the chart elsewhere that the benefits of exercise have been discussed to help with depression, the benefits of sleeping, and at least an 8-hour duration, nutrition, those types of things. So if somebody is positive for the depression screen, we do want to intervene and we want to document that intervention. Going down to the elder maltreatment screen, that is the middle part of this that everybody's going to fill out. Now this is a little different. Technically, if a person circles only one of these yes, then that would be a positive screen. And in that case, this person would need to have some intervention, and that intervention would include being referred for protective services, and we will have that policy in place so that you can do that if needed. What's not on this is the therapist's responsibility, so you'll see that there's 4 questions here. The last question that doesn't appear is basically whether or not the physical therapist feels like there may be elder abuse taking place, maybe based on bruising that's been noticed, lack of eye contact, just something that the patient says to you. That is also going to trigger a positive result on this screen. That's one that I don't look forward to. It's going to be a hard call on whether or not we refer somebody for protective services, but evidently it's a very big issue out there, and it's something that we should be proactive, and of course Medicare wants us to be. Now lastly, although everybody has a fall assessment, not everybody has to have a falls plan of care in their chart. So that patient that fills this out that they've fallen 2 or more times in the past year, that would trigger this thing being a positive result. Or maybe they haven't fallen twice, maybe they've only fallen once in the past year, but it resulted in injury. Well, there's a yes there as well, and so that shouldn't be there. So with that yes, that would be enough to trigger a positive result on this screen. So whether or not it's a yes to number 1 or a yes to number 2, either of those triggers a positive result on this screen. And then basically when that happens, we just need to attest that in our treatment plan, which is found in the objective portion of our chart, in that treatment plan, we're going to be working on things like balance and strength and gait training. And those are things that we do anyway. So just to clarify, that would be if, again, Medicare came in and audited us and they said, okay, this person had a positive and this person needed a falls plan of care, where do you keep that? Then they would be directed to the objective tab, which actually we're already on, and that's your plan of care right there. So it would fall, it would show up somewhere in that plan of care that you established first day. We might even refer to that plan, but that's not really the way that we chart. So again, it should be somewhere in here. And that's not to say that all of these issues have to be documented, but at least one out of those should certainly be documented. And again, that's not in addition to what we're already doing anyway. So that's the process. There will be changes, I'm sure, as we get rolling with this. Again, only initial evaluations, but although these only need to be done on initial evaluation, make sure that the functional limitation reporting that we attested to up here in number 1, make sure that there is a follow-up questionnaire given to the patient and calculated and in the chart, so that we can demonstrate that we are following up on those whenever possible. Thanks a lot.